Rahman Rahim. In order to keep our program in time, we will start. In spite of a lot of people still, I think, at lunch. It is an important seminar, it is an important session, because I think there are a lot of failure of ACL because of a lot of ACL done now. So it will be discussed about the failed ACL reconstruction. We'll start with Professor Nikolaou from Greece about the ACL functional failure stiffness.
Good afternoon. I'm very glad to be here. As I discussed with my colleagues, we are cousins. Greece and the Egyptians, we are cousins. And this old civilization that we represent, I asked to be united and to combine meetings as the Greek Orthopedic Society, that I was a president last year, and the Arthroscopic Greek Arthroscopic Society to make a combined meeting to go on with the new things about knee surgery. I'll come in a sad vision of our talks, the vision of failed ACL. And the complications that happens after an ACL, reconstruction. The complications, I believe, is when a patient has an outcome that is less than he expected. Patients usually want the knee to be the same as before and the same as is the other knee, and mainly about the athletes to go back in the field as better and as soon as possible. And of course, we doctors and the patients, we are hoping that with a very good operation can prevent the future development of osteoarthritis. Laval in the early 2000s make an algorithm about the ACL failure. About the ACL failure. In this big algorithm, I'm going to focus in the loss of range of motion. And even the terminology about this fact is a little confusing, misleading, or misunderstood. Words as stiffness, arthrofibrosis, ankylosis, flexion contraction try to represent this problem. I believe that the genetic term motion loss in flexion and in extension more precisely describe any deviation in hip motion from the normal, the contralateral side. The incident is not easy to find it because the motion problem after ACL reconstruction is unknown and varies according to the specific injury, how was the injury, the treatment modality, and how motion loss is defined, how everyone can define the loss of motion. There are several factors who are depending on the injury, of the treatment that was followed, and the rehabilitation protocol that was followed. These factors is the time of surgery, the preoperative motion, the concomitant secondary strain repair as the rupture of the collateral ligaments, the iliotibial tenodesis or suturing of the meniscus, the malpositioning graft, the extensive graft tension, even this can lead to a loss of motion, the prolonged immobilization, poor rehabilitation, infection, and also this pain syndrome, the CRPS syndrome, and the arthrofibrosis. Let's see one by the other, all these things. For the time of surgery, here we have a controversy. And this controversy is because there is lack of uniformity among patient selection, different surgical techniques, different post-operative rehabilitation, and of course, different kind of follow-up data. There are many papers that are presenting these facts. There are papers that say that the early surgery, which is less than 3 weeks, is associated with loss of motion. And there are others that say, no, it's not. These are some of these papers. Let's see the late, who are proposed the late surgery. Appears that dilating, when there is a persistent loss of motion, inflammation, or swelling, decreases the risk of motion problems. Advantages of waiting include also mental and physical preparation by the patient. Before surgery, we need good motion and strength of the knee, and they need to be ready to have surgery. Early surgery, especially in high-level athletes, they don't like to lose time. So we are going faster, as fast as possible, to do the operation. And there is another factor. Early surgery may facilitate the surgical dissection, repair, or reconstruction because the knee is less distorted by the fibrous healing process. Of course, the American Orthopedic Society for Sports Medicine make a statement, and the statement was, do the surgery when the knee is ready. Never mind is early or late, the knee must be ready to have good motion and, as possible, less effusion. Another factor, another risk factor is the proper graft positioning. Also, the proper graft tensioning and the addition of concomitant secondary restraints. This is about the surgical technique, how we do the surgical technique and how we use the different types. The proper graft positioning. If the tibial insertion is too far anterior, we know that there will be impingement in the roof of the intercondylary nodes in extension, so it's going to limit the extension. And this is too far anteromedially, going to limit the flexion. How about the femoral insertion? Extensive strain of the graft leading to limited flexion and potassium graft failure as if we put the femoral insertion too far anteriorly, as you can see into these slides. How about the tension? Most of the surgeons prefer to tension the graft and to fix the graft in 30 degrees of flexion. My opinion, and in my cases, I do it in full extension. I tension and I fix the graft in full extension. Of course, this is depend how well we have do your tunnel and how well you did your surgery. Another risk factor is the concomitant restraint repair. It is sometimes developing scar tissue or the so-called Pellegrini's tieda in the medial collateral ligament, if you repair the medial collateral ligament, and extensive extra-articular soft tissue dissection or trauma, the development of soft tissue calcification or myositis ossificans also may result in secondary loss of motion. Also, if we suture the meniscus, sometimes we develop a posterior contracture of the capsule if we don't put in very good position our sutures. The post-operative rehabilitation. It is obvious that prolonged immobilization has serious determinant effects on articular cartilage bone and soft tissue envelope about the joint. Suboptimal rehabilitation resulting from poor instruction or poor motivation will affect the patient's overall recovery. Full extension and motion initiated as soon as medically possible. I know that most of us we move the knee as soon as possible after the surgery. Two other reasons is the infection. The infection has to discuss in a special moment, is so many the effects of the infection, and also the pain factor, the so-called CRPS syndrome. And let's go to the main thing that is the arthrofibrosis, who is a wide spectrum of conditions, all of which ultimately result in loss of motion. This spectrum of involvement ranges from poorly localized to vastly diffuse with varying degrees of intra and extra articular extension. Can be categorized into three types of lesion that vary in severity, presentation, and incidence. And this is the cyclop lesion or local arthrofibrosis, the infrabatera contracture syndrome, who is first described by Poulos, Lonnie Poulos, and the global arthrofibrosis, who is the most serious of these conditions. First, let's see the Cyprus lesion of local arthrofibrosis. This is a fibroproliferative scar nodule anterolateral to the tibial tunnel composed of dense fibrous tissue with central area of granulation tissue. With extension, painful impingement occurs between the ACL nodule and the intercondylar nodes, blocking terminal extension. The hypothesis is that the anterior placement of the graft, especially in the tibia, resulting in injury of the graft and subsequent nodule formation. Another reason is that fibroproliferative tissue response originated from either debris from our tunnel in the tibia and remnants of the ACL stump, or more rarely, from loose or broken graft fibers. Here the treatment is arthroscopic excision with little or no manipulation. This is a young lady on your left that after my surgery had this limit of extension. We did arthroscopic examination. We found this big nodule that was excised by the saver. This seems to be from debris from the tibial tunnel because it was a kind of bone formation, and in the back you can see the ACL who was intact and safe. Another arthrofibrosis factor is the infrabatera contraction syndrome, which is described by Poulos, Lonnie Poulos, and Rosenberg. This is scar tissue which is developing in the gutters and behind the patella, behind the patella tendon, and mainly we found it after the patella tendon autograft. Sometimes when we do acute surgery. Of course, sometimes the poor graft placement affects this condition. The treatment again is arthroscopic lysis with manipulation. Again, here is a person who was developing this. You can see the pictures of the knee before the cleaning in the left and after the cleaning on the right. And the most serious is the global arthrofibrosis, who is a periarticular scarring, restrict flexion and extension. Cytosine stimulate the cellular response that results in fibrosis of the medial and lateral gutters, as well as the suprapatellar patch. When fibrosis occur in the anterior compartment, it will often be accompanied by posterior medial or posterior lateral fibrosis. The most severe form is also associated with extra articular involvement. The treatment requires specific surgical approach. And there are in this condition, some salvage procedures. I remember Jack Houston said that no one can do a so bad knee than a surgeon can do it. Usually, this happens after bad surgery. So sometimes there are final salvage procedures in the rare patients for whom no other manager is successful, the arthrodesis, as you can see in the bottom. The rehabilitation, as I said, we have to do special protocols and to follow special protocols to have the best result. But I can tell you that no one good protocol can do faster the return of somebody in athletic activities. We have to wait 6 to 9 months after the operation. But we have to start as early as possible to give movement to the knee. Take-home message. Back in the 80s, we believed that the good surgery is to do a stable knee. Knee stiffer than normal provide us with confidence. Now we like just to show it, yes. Now we like stable and normal knees. Now this is the goal. And this is not possible without equal range of motion. A stable knee without a full range of motion is a complication. Patients may not be able to get their strength and confidence back. Has higher chance of developing early osteoarthritis. A failed ACL from laxity, but with range of motion, good range of motion, may be better in the long term than a stiff knee. In conclusion, and this is the main thing I'd like to share with you, is the main complication with ACL reconstruction are range of motion loss, inability to return to desired activities, developing osteoarthritis in the long term. Achieving stability at the expense of perfect range of motion causes these complications. Thank you very much.
Thanks, Professor Nikolaou, for this nice talk. Is Dr. Ahmad Wally is present here?
No.
Yes, welcome. The second talk is about arthroscopic ACL revision by Dr. Ahmad Wally.
Good afternoon. We all ate. I hope that we can concentrate and I can concentrate to say my lecture. My talk is about ACL revisions. I'll talk about a bit of the causes of failure, the approach to the ACL revision, the decision making, arthroscopic techniques, and the outcome of revisions. Of course, the ACL reconstruction is the gold standard now for all ACL tears, but 2 to 11% of them will return back with re-rupture. In the US alone, there is 13,000 revisions per year. So, and the outcome is much more inferior than those of the primary ACL. The non-anatomical tunnel placement is one of the common causes of the graft failure. Revision, you can do it in 1 stage or 2 stages, depending on different things like the size and location of the first tunnel, the bone stock, if there is existing hardware, and if there is infection or not. As well, the cause of ACL failures most commonly are the traumatic ones. And if you are lucky, you'll have a patient with a traumatic tear of the ACL, so that the tunnels are in the good place and there is no widening and no other problems. The second cause is the tunnel position. Following this is the missed any instability causes of the knee, or there is malalignment. To evaluate the ACL tear after reconstruction or failure, you have to start with a thorough history, including the reason of the tear, if there is an injury or not, the post-operative course and range of movement. The patient expectation is very important in the secondary or the second time ACL rupture, because as we said, it's inferior than the primary ACL reconstruction. Physical examination is very important, especially the gait, if there is any malalignment like varus or valgus, if there is a fusion, if there is a stiffness, the quadriceps function, which I always say to my patients, the quadriceps is very important. It's the sole of your knee. Without it, you won't have good results. Radiographs, including all the plain X-rays, including the Schuss view, the AP standing views, the lateral views, the skyline, you have to do a CT scan, an MRI scan, all of this to assess the tunnel position, if it's right or not, if there is tunnel widening, the tibial slope, how it is, if there is any cause other than trauma that caused the injury. If there is any missed lesions like the root lesion or ramp lesions in the medial meniscus, which wasn't dealt with. So revision ACL reconstruction is indicated in symptomatic unstable knee interfering with the patient's activity level or the desired patient's activity level. And it is contraindicated mainly in infection or severe arthrofibrosis or psychologically unstable patient that will cause your reconstruction to fail again. So how to make the decision? Well, if it's a traumatic graft failure with well-positioned tunnel, then as I said, you're lucky because it's going to be in a single stage. You are going just to redo your tunnels in the same place, remove the fixation device or instrument, put a larger graft, most probably with bone grafting, and if you need extra articular tenodesis, you can do that as well. What if the tunnel is malpositioned? Then you've got two scenarios. If it's going to not to interfere with the new tunnel, then this is easy. Just leave the old one alone and do the new one. But if it will interfere with the new tunnel, then you have to do a divergent tunnel technique or two-stage revision if there is a widening as well. What about malalignment? This is going to be discussed in the next lecture, but you can do the osteotomy with the ACL reconstruction in one stage or in two different stages. If the slope is exaggerated, then you'll do osteotomy to improve your slope and help with the stability. If the tunnel is wide, again, you're going to look at it. If it's 10 to 15 millimeters widening, then you can do it in one stage. If it's more than 15 millimeters, then you have to do two-stage revision. If there is any missed instability, like the posterolateral corner, posteromedial corner, or there is root repair or ramp lesion, you've got to deal with this as well with the revision of the reconstruction. Enough talk about the stiffness. It's already covered with the previous lecture. And now the single-stage revision strategies, either you do the divergent tunnel technique, as I said, or a matchstick grafting technique or stacking screw technique. What is this? Well, the divergent tunnel technique, if you've got the tunnel in the same place that you want or it's a bit wide, and it is anatomical, for example, then you've got to do a divergence. You start with your tunnel away from this tunnel, but it reaches the joint in the same anatomical point. The aperture of the new tunnel remains unchanged. And you must keep a good cortical space or bridge between the two tunnels. The stacking screw technique is you put more than one interference screw in the tunnel because it's wide. So you might put just one large screw, mega screw, and a small one beside it, or two similar screws in the same place. What about the the matchstick grafting technique? You take slivers or bullets of grafts and you put it inside your tunnel, and then you put your graft and you put your screw to fix your graft. Well, this is the one stage revision. The two-stage revision strategy, it's indicated if it's double bundle ACL reconstruction or revision of infected ACL post-stiffness tunnel widening more than 15 millimeters and enlarged malpositioned tunnel. In all these cases, you have to do a two-stage revision. The first stage is you do a debridement. You remove all the fibrous tissues, and if there is infected tissues, you remove everything, and you do adequate debridement of the sclerotic tunnel. You can put your bone grafts, you deal with any other pathologies that you found, so that the second time you just do a simple, easy, quick ACL. When you do that, 3 to 4 months after the first stage. Now, if you are going to go to do the revision, you have to be ready. You have to have everything in hand. You have to have staples. Even though you did your preoperative planning, you checked your x-rays, your MRI, your CT, you still can find some surprises there. So you have to be ready. Screw and washers are very important. You have to have anchors, bone graft substitutes, large interference screws, and you have to have as well a fluoroscopy control if needed. You have to examine your patient under anesthesia before you start. Examine him thoroughly to determine any rotational instability or unrecognized PLC or PMC laxity preoperatively. The portals, you don't have to stick to the old portals. You can do completely new portals depending on what you want to do. To visualize, you have to have a panoramic view. You have to have a good anteromedial portal and central portal to deal with the old implants that you are going to remove. You have to see the old tunnels, if there is any dilatation that is not obvious with the x-rays and so on. So the portals are very important. You have to do a good debridement, remove all the ACL, all the old ACL, any cyclops lesion, any fibrous tissue needs to be removed. You have to look at the notch, because if it's old, you might need a notchplasty. Deal with any intra-articular pathology as needed. If there is ramp lesions or root repair, you need to fix before you start your ACL reconstruction. Any chondral lesions need microfracturing and so forth. And after you do all of this, you look at your tunnels and you start deciding or confirming what you want to do, which graft you want to use. Check all tunnels, complete visualization of the femoral and tibial footprint, check the tunnel position and widening, remove all the hardware as we said, if it's loose or not, you have to remove it. If you can't remove it and you don't have the history of what implant he's using, then you can over drill or drill the bioabsorbable screws in place and do your tunnel, remove all the plastic bits, remove all the fibrous tissue. You have to have a bleeding bone around your graft. Suspensory fixation devices or screws and washers outside the tunnel, you can leave as they are. The femoral tunnel, you have to have a very good view. You have to clean it perfectly well. And if you need a divergent tunnel, then you can do this. As we see here, there is fibrous tissue inside the tunnel and it needs to be completely removed. With the tibial tunnel, go through old anatomical tunnel if possible. If posterior tunnel, then use an anterior one and so forth. Must avoid graft impingement, so be careful with the notch. The fixation, you can do simple fixation with an interference screw if you have good bone stock, but if not, you can use suspensory fixation as well as interference screw. Like in this picture here, you can see there is suspensory fixation and it wasn't good enough, so I just put a new, another interference screw. So combined fixation is very useful sometimes if you have weak bone or wide tunnel, and you are not happy with your fixation. You can as well augment and protect your graft, and I do the lumbar or extra-articular tenodesis in most of my revision cases. And you can as well put brace post-operatively to secure your graft. If severe bone loss, as we said, you have to start with the first stage with bone grafting, and then few months later you can go and do your ACL reconstruction. Post-operatively, you have to go slowly. You have to be very careful with your patient, very good physiotherapist, and reach your full range of movement by 6 weeks, not 3 to 4 weeks with the primary ACL. Make sure the core stability of the patient and the quadriceps are good. Return to sport not before 12 months with the revision ACL. There is a general consensus that the outcomes for revision ACL reconstruction are inferior to outcomes of the primary ACL, as we said. The overall graft failure with the revision ACL is 6 to 25%. So there is high rate of failure of the revision, and less than 50%, I would say maybe 70% of patients are not going to return to the sports they were doing, and they will change the sports or they will be in a different level of sports. Thank you very much.
Again, I appreciate the opportunity to speak, and I think, as Dr. Nikolaou stated earlier, I think a stiff knee is the worst knee you can have. And then I thought Dr. Wally did a fabulous job of outlining the areas of taking on patients in revision surgery. I'm going to sort of get to that last resort issue when, quote, all has failed. These are my disclosures. So I think as we talked about earlier, the things that I would like to cover, the general thoughts on why ACLs fail. We discussed the treatment options. I think Dr. Wally did an excellent job. And then the role of osteotomy, as well as the technical pitfalls that can certainly occur with that. Here's the clinical scenario we all sort of face. You know, you got a 42-year-old female. She's had 2 ACLs done by very competent surgeons. One was an autograft, second was an allograft. And then appropriately so, in the second surgery, he used a iliotibial tenodesis to augment that. And unfortunately, she's still now left with pain and instability. And so I think that's the hallmark of what I want to sort of make sure you're thinking in your algorithm. Am I treating pain? Am I treating instability? Or am I treating both? And that's how you should break up your thought process. So why do ACLs fail? We talked about, you know, certainly if an ACL is performed poorly, we can always blame the prior surgeon. That's one thing that orthopedic surgeons are very good at. We love to blame our colleagues, but we shouldn't. We know that maybe a graft size was not appropriate. We know that sometimes patients went back to sports and activity too quickly, and we didn't do a good enough job of sort of looking at them. But the one I want to talk about a little bit more is the patient really has a structural defect. They've got an increased posterior tibial slope, which led to graft failure, or they have a varus alignment associated with meniscal loss or cartilage loss and are essentially complaining. Really the first science to this topic started to come back in 2004 when Bob Giffen, who's in London, Ontario now, and Chris Harner sort of looked at the slope component. What does that actually mean? And this data was really expanded on further over the years, and a more recent study by Dr. Laprade really clearly shows that the greater that posterior tibial slope, the more dramatic the forces on our graft. Even a well-placed, strong graft with proper technique will eventually fail given these circumstances. And no, there's no demarcation where a right slope is correct and a wrong slope is incorrect. it's really a soft graft, but arbitrarily we're sort of getting to that point where we think that number is anywhere from 8 to 10 degrees. So in dealing with a complex knee patient with a failed ACL and meniscus loss, we can have a biologic approach. In America, we love to stick in cartilage of every which way, shape, or form, and there's all kinds of articular cartilage cell therapies. But really, again, I think I want us to think more about the structural approach. And really, I believe that bracing is really a reasonable approach in my patients, and I think it helps me, number one, get comfortable with the new patient that was referred to me with failed previous surgery. You never want to operate on a patient who's had failed treatment by other surgeons on the first visit, in my mind. I think you're setting yourself up and the patient up for unrealistic expectations. And so, you know, the orthopedic principles we guide by, number one, you cannot correct a bony deformity with a soft tissue procedure. It just doesn't work. Number two, an economic principle. Well, in America, as I said, we're a little foolhardy with a lot of our technologies, but I think Roman Seal from ESCA, at his address 2 years ago, said that osteotomy is the knee cartilage procedure of choice in Europe, and I'm sure it may be so in the Middle East and in North Africa as well. So just to get our definitions down again, we think the mechanical axis is anywhere from 0 to 3. The femoral tibial axis, we're going to say normal is 5 to 7 degrees, and that tibial slope we'll say is less than 10 degrees. Now, clinically, if you're a sports medicine physician and you have a team full of girls, and on that team you may have 8 out of 25 girls that had their ACL reconstruction, you can guarantee yourself at least 1 or 2 of those girls will fail at some point. And unfortunately, on the second injury, will often suffer significant meniscus damage. And then you're dealing again with that situation of both instability and now the development of pain and/or the possibility of arthritis. As I said earlier today, gait to me is the most clinical important examination. Our static exam is fine, but really how patients walk and move. And as you saw the girl from the upper quadrant, you know, she's got a big mouth. I think to expect that her graft's going to survive is really unrealistic. In the lower quadrant here, you see a man who's referred for osteotomy. He's varus and bow-legged, but I should send him to Dr. Nikolaou. He's got a stiff knee, and a knee that doesn't bend is not worried about instability, and making an osteotomy will not improve his condition as well. You want to image these patients thoroughly. So full standing mechanical axis x-rays are critical. Identifying the degree of arthrosis they have helps you prognosticate the relief of pain and the length of time you're going to give these patients. Obviously, advanced imaging is critical. There was a great study by Stefano Zaffagnini from Italy, and I'm sorry the Italian Italian compatriots could not make it, but really they did a wonderful retrospective study, and they looked at patients who failed multiple revision ACLs. And in the control group, the posterior tibial slope was averaged only about 4 to 5 degrees, whereas in the first time failed ACLs, the slope averaged 10 degrees. And there are multiple revision cases where patients that failed 2 ACLs, the average posterior tibial slope was 13 degrees. And while did this slope develop? I think it was just not fully recognized by us at the time we're treating these patients in secondary surgeries. As I talked about earlier, I do like the use of unloading braces. Again, it's what we call dating in America, allows us to get a comfort level with the patient. I do believe that they do get some relief of pain or valgus deformity. I think the study, the Scandinavian study, would show that there is clearly some patients who get relief. Now, it's not 100%. If it's only 50%, I still think it's worth the trial. And do patients actually wear them? Well, probably on a prolonged basis, only about 1/3 of the patients will actually say, "Doctor, thank you for the brace. All I do not want to make a painful operation," and they say goodbye. Now, if you truly have an isolated increased posterior tibial slope with no significant meniscal damage, and you've got a failed prior ACL reconstruction, an isolated anterior closing wedge osteotomy is a reasonable approach. Now, I think many of us are generally uncomfortable with that because it's generally performed above the level of the tibial tubercle, and it's an area we're cutting front to back that we're not that comfortable with. But in selected situations in patients with solid bone, this procedure is relatively straightforward and relatively simple. Now, here's the more common scenario we have. Previous ACL reconstruction, hamstring in 2016, soft tissue allograft 2018, low energy non-contact secondary injuries. Now she has pain with activities of daily living. Her physical exam reveals she's generally hyperlax. She's got a fair amount of motion. She's got a grade 3 pivot and a grade 3 Lockman, so she's pretty unstable. Her collaterals are thankfully intact. If you look at an x-ray, you know, she had a prior ACL reconstruction on the contralateral side, a little bit of a vertical tunnel, but she's asymptomatic. And it's certainly on the operative side, a well-placed tunnel, a little bit of dilation. But if you look at it as time, she's got an increased posterior slope. She's sitting about 12.5 degrees, and maybe we did not recognize why she failed in the first place. And so 13 degrees is clearly above that 12-degree mark, which I think is well accepted. In my mind, I've dropped that number down to 10 degrees posterior slope. Is really a time when we're going to get interventional. Now, I believe the standing mechanical x-rays, if they're asymmetric and if they're tipping in the valgus, I think you've got to be more aggressive. And certainly in this situation, after her first ACL, she lost the majority of her meniscus. We know the situation is only getting worse. ACL deficient, varus alignment, meniscal division. There's no graft in the world that can survive in this environment. So our treatment options are, well, ACL reconstruction, single or two-stage. And I agree with Dr. Wally's recommendation. 14, 15 milligrams is generally that cutoff. You have to go one way or the other. Do we do an osteotomy? Are we trying to achieve just mere stability, or are we going to ask for lasting pain relief and function? And then finally, the last decision, which we have in America, more the ability to perform meniscus transplants more aggressively. So in the first case, we took out our hardware, we did an osteotomy, we bone grafted her ACL tunnels, we tried to correct her slope. We did a standard bone graft technique. It was previously shown. Generally, I believe you have to wait a minimum of 8 to 12 weeks. I think when I've gone in at 8 weeks on these, I don't think that the bone is consolidated, whether I use a combination of allograft and autograft or bone putty. I believe that 12 weeks is most appropriate if a patient can handle that time frame. And I think the literature would support that a two-stage, well-performed revision with solid bone stock does work well. So at second stage, we took the ACL plate out. We did do a meniscus transplant. We did a revision ACL with her own tendon, which is, again, our optimal graft that we use. Unfortunately, in this case, she's stable and pain-free at 2 years. Here's another interesting case. A 32-year-old woman, recreational athlete at best. She had a prior tibial fracture in her adolescence with a 28-degree tibial slope, a 3.5, 4 centimeter limb length. The decision points here, putting a graft in this knee will never survive. And I sort of decided, maybe inappropriately so, that I was going to take on her limb length discrepancy at the same time. And so we did, at this time, an Elizaroff bone lengthening to both correct her length and her posterior tibial slope. In hindsight, I would tell you, just fix the slope and stop. I think I did too much, and it was a very traumatic event to use a Elizaroff to try to gain length. Fortunately, the surgery was successful. So the indications for an osteotomy, in my mind, under the age of 50 in males, under the age of 45 in females. Generally, females over the age of 35, in my experience, do not do osteotomy. Obviously, you're looking for tibial slope change, ligament healing, and more commonly, protect articular cartilage. So the indications for a mini osteotomy or decompression osteotomy is a ligament transplant and cartilage surgery. The contraindications, we talk about anybody with severe arthrosis or lateral tibial subluxation, in my mind, is doomed to fail, and I would avoid it. Contraindications, absolutely, inflammatory arthritis and limited arc of motion. An osteotomy is a stiffening operation. They will lose some motion, and you better plan on it. So you have to correct how much correction you want. 62 degrees if you're doing it for arthrosis and true varus alignment and pain, into 55th percentage point if you're only doing a decompressive osteotomy for cartilage surgery. The older techniques, which I no longer do, the opening or closing wedge osteotomy, relatively simple, straightforward, I felt, allowed immediate weight bearing. And generally, it's performed from a lateral approach. Unfortunately, the risk for artery and nerve damage is a little bit higher, and I think that delayed time of closing the wedge sort of made many surgeons nervous. And so nowadays, I think most surgeons would prefer proceeding to an opening wedge osteotomy, which I think is better than 95% currently in North America. So the closing wedge still has, in my mind, indications that should be considered. The opening wedge, very straightforward. You're just basically a single cut. You don't have to rely on how much on getting a perfect closure. In my mind, the critical element is making sure that you've that you've got that tibial slope parallel. And so keeping that knee in a position of flexion is very important when you're placing your guide pins. I always use 2 guide pins to make sure that I've got a parallel osteotomy. In my mind, if I'm taking more of an 8-degree wedge or I've got any kind of risk factors, including smoking or poor bone quality, I will use a tricortical iliac crest. If it's basically a small osteotomy or in healthy patients, I think minimal bone grafting is necessary, and many of these patients will heal. I will say the technical pitfalls are, it's an osteotomy. You're cutting bone. Make sure you measure twice, check it 3 times, and then finally before you make your cut. Fracture is the most concerning one, and I believe that it's all due to orientation. If you start your osteotomy too close to the joint line, it's too easy to fracture in, as you see in the x-ray in the bottom. And I believe that the larger the patient, the greater the risk factors, the stronger you have to have in terms of the fixation. The other one is it's too easy in an opening wedge osteotomy to actually increase that posterior tibial slope by putting your plate in that anterior position. It de facto opens the joint anteriorly and increases your slope. So you really have to fight that tendency. Now certainly, if you crack the lateral cortex repeatedly and you put insufficient hardware in poor prognostic patients, you're going to end up with this situation, which in this case I said is the trifecta of poor obese male, smoker, and work-related injuries. In the United States, we have heavy litigation, and these patients are doomed to failure, and this patient was referred to me and required what we would definitively call the dead bone sandwich to try to reconstruct this situation. So the higher the risk patient, the larger the implant, and I do believe that a large synthes type plate is appropriate. For ideal candidates, I think you can get away with the smaller, lesser invasive devices. I believe in certain situations like this, it's an ideal operation, knee dislocation, multiple operation, stabilized knee, unfortunately in varus, a failed posterolateral situation, and now again, we reconstructed this with a wedge osteotomy. The patient was fortunately pain-free now 10 years after surgery. So one last thing before I stop, PCL deficiency, a patient had a PCL reconstruction, residual pain, residual swelling, grade 2 drop back, still had an intact graft by MRI. In this case, we did an opening wedge osteotomy and intentionally increased the posterior slope. It improved his posterior stability and led to the need for further attempts at reconstructive surgery, and the patient was quite happy at that point. My time is up, and with that I'll stop. So I thank you for your attention.
We start the discussion because we are delayed in time, so very short questions for everyone. We start with the first talk, Professor Nikolaou from Greece, about the ACL functional failure, the stiffness. Any questions? Rahman.
When you combine ACL reconstruction with meniscal repair, do you improve herniation of the patient or delay flexion of the patient?
When I repair the bucket halber, and I do the same at the same time the ACL. So I use the protocol for the meniscal rupture, for the meniscal suturing, keeping the knee in 0 to 90 degrees of flexion right away. No weight bearing, full weight bearing for 4 to 6 weeks, depending of the type of suturing that I was happy or not. And I follow then the rehabilitation protocol of the ACL.
And also, if you have remnant of the ACL, remnant of the previous of the nature of the ACL, do you shave some of them or do you preserve the remnant and you don't?
Okay, to tell you the truth, after 35 years of ACL reconstructions, in the beginning I was believing that remaining remnants of the old ACL can help in proprioception. Now I don't believe it. So I clean everything before I do my new operation, and maybe this helps in the rehabilitation movement.
Thank you.
Dr. Ahmad, any question for Dr. Wally?
Question for Dr. Nikolaou. What are your thoughts on the use of I'm sorry, what are your thoughts on the use of corticosteroids in the post-operative period in managing these patients, the stiffness? Do you use corticosteroids, and when and how often?
I never used, and I'm ready to hear your opinion. I never used.
I'm not sure what the experience of others in the room, but I'll be honest, I'm very aggressive with it. So if I have a patient who I believe that at 6, 8, 10 weeks is showing significant signs of fibrosis and early on, we are now using Medrol dose packs, as we call them, a steroid pack, and I have no problem with that, because I think that patient that's having what we would call the overly aggressive biologic reaction to surgery, that patient, I think, is at great risk for fibrosis and motion loss. So we felt it's been, Dr. Bach and myself in Chicago, we use them relatively aggressively. We've had no incidents of avascular necrosis, and we think that it's significantly decreased our necessity of post-operative arthroscopy and lysis of adhesion. So I would consider that.
How many injections, sir?
The first time I will go is 8 weeks, but between 8 and 12 or 16 weeks, I have no problem doing it at all. And it's delayed, it certainly decreased my amount of secondary surgeries for motion loss. So, and I know there's a theoretic risk of avascular necrosis associated with steroid use, but it's exceedingly small. The only literature where there is any complication in isolated Medrol dose packs are really in ophthalmologic issues. But we use Medrol and steroids all the time for patients with sciatica and other issues, and our allergy and immunology colleagues use it all the time for patients who have rashes. So I think it works well in this situation, and I would consider that.
Questions to Professor Dr. Ahmad Wally?
I want to comment about corticosteroids.
Yes.
Okay.
I was working with a surgeon in Italy called Mariani, and he was routinely giving 8 milligram dexamethasone immediately after tourniquet release in ACL. So I started to do the same after him. I don't know, but he always do corticosteroid at the end of the surgery. He gave the patient systemic 8 milligram dexamethasone as an anti-inflammatory shot immediate after the tourniquet.
Systemic.
Yes, systemic.
دكتور أيمن بيه؟
Do not look.
دكتور أيمن.
Just a comment in regard to the intravenous corticosteroids being given at the time of the operation. It's totally different from what we are talking about in relieving some of the fibrosis in the joint. I think what we're talking about is controlling patients' pain. And this is something that's being used as a protocol of prophylactic analgesia, we say. So it's a combination.
He used a block, an anesthesia block, so there is no pain, but as an anti-inflammatory to prevent fibrosis and decrease the inflammation of the surface.
That is all to do with a package of multimodal analgesia, and the multimodal analgesia would include the local blocks, the intra-articular injections of local anesthetics, as well as the corticosteroid systemic, which is totally different from what's being alluded to as relieving of the fibrosis.
Just a quick answer for Dr. Mohammed. You can use systemic steroid just to prophylactic against stiffness, but intra-articular proved that there is some dangers for the articular curvature. I think it is another issue than treatment of stiffness. I don't like actually intra-articular injection to start with. I don't know the opinion. Dr. Ahmad.
Not all the steroids are the same. Triamcinolone is not deleterious for the articular cartilage, but other steroids are.
Okay, let's go to the second talk. Yes, Ahmad Wally, any questions for the arthroscopic ACL revision?
Okay, excuse me, I'm just continue in the same topic, excuse me for this, but I heard Dr. Elnour says that he used to do a systemic, right? Systemic injection after tourniquet release. Systemic, he said systemic. And Dr. Ahmad Abdel said that the triamcinolone is safe for articular cartilage. So in a situation like ACL repair or meniscal repair, do you have a recommendation for triamcinolone injection? Triamcinolone.
Triamcinolone, yeah. It's not catabolic for the cartilage. That's what I'm saying. But of course, if you have something to heal, like meniscal repair or ACL, I don't recommend
steroid will hinder healing.
at least in the first few weeks.
Okay.
Maybe with chronic effusion,
I
when you
was
have all the
making sure.
infection markers normal, you might use it.
Okay, I was just making sure that I'm doing all right.
Dr. Ahmad Wally, I have a question to you. About the revision ACL. What do you think about the statement saying not every ACL failure is for ACL revision? Not every ACL failure is indication for revision.
You mean that not everyone who's got an ACL failure, you've got to do the revision. You can just conservatively treat him. Yes, of course, I believe.
Because I believe in this statement, actually.
I believe in this as well. Pardon? Okay, if the patient is going to change his lifestyle, he's a 40, 45 years old, and he's going to stop playing sports, for example, or he's
so you will put a protocol for the patient who had failure, so you will put him on a protocol clinically and symptomatology and radiology.
Yeah. I mean, if he's not doing contact sports anymore, and he's going to go swimming or jogging, and it's enough to put a brace on. If someone having ulcers or instability, and I'm going to do osteotomy, for example, so I'm going to play with the slope and give him a bit more of stability. So I'm not going to do an ACL reconstruction, has chondral ulcers, and I mean, there are lots of cases where there is an ACL, overweight patients. Someone did an ACL, and he's overweight, he has re-rupture, and he's coming back, and he's, let's say, 200 pounds.
It is very important message to be.
Very weak quadriceps, weak core stability, that will lead to another failure. And I would try first physiotherapy, core stability, increasing of the quadriceps muscle, and see how he's doing, and then I'll decide if he needs or not.
Dr. Hassan?
Usually ACL tear doesn't cause pain. It doesn't. It's the complications. It's the complications after the ACL. So I will try to find the source of pain. It's not the ACL tear. We have to thoroughly investigate him, because he must have a chondral ulcer. He might have a ramp lesion. He might have patellofemoral arthritis. Instability, I think, would present with instability, giving way, maybe lateral thrust, things like that, but not with pain, unless it's complicated with something else.
Yeah, I'm going to ask the next speaker.
Professor Charles?
Yes, the last speaker.
Professor Charles? Yes, please. Question from
the question is Professor Charles. Yes. Okay. If you have that case scenario of someone who is complaining from failure of the ACL graft instability, but he has a significant degree of a varus deformity, do you tend to do both simultaneously at the same time, or to correct the varus deformity in a separate operation?
You know, I think as one of the questions just posed, these are salvage cases, not restorative cases where we're trying to make the patient normal. Frank Noyes, who I did my fellowship with back in the late 1980s, we followed a series of patients that had what we called the triple varus knees. And we did we did osteotomies on 75, but only 35 actually came back and said, I want my ACL fixed. So I think the majority of patients who have failed 1 or 2 operations, they just want pain relief. And what we found that doing an osteotomy, I think alleviates the majority of their pain. And they decide, do I really want to go back and put my knee at risk, risking instability? So I would say the indications for doing a simultaneous ACL revision with an osteotomy is the young patient under the age of 25. We really anticipate that they will have a high-risk lifestyle no matter what you do. Over the age of 30, I would never do that. That's just my personal bias.
Charlie?
Question to Professor Charles. Okay.
I want to ask about the tibial slope. The tibial slope, it's different from race to the other. It is even more towards the our race more than the white race. We tend to kneel most of the time, so our tibial slope is definitely more than the tibial slope of those who do not kneel. So do we look for in the if there is a failed ACL and tibial slope is high, do we do another lateral view for the other side? And if it is the same, will we still correct the tibial slope?
I agree with your premise. Number one is that cultural issues influence bony deformity. We see that in the United States, and when we have young adolescents and even pre-adolescents who throw a baseball a lot, they develop a significant asymmetric rotation to their arm. They increase humeral torsion by 25 degrees, and it's adaptive. And we see the same thing in young soccer players in Sweden who begin playing soccer 12 months a year. At age 8, that they have a much greater incidence of femoral acetabular impingement because they're running in their sport. And so it certainly, as soon as you said that, it came to me right away that yes, with your culture and religious values, if you're in that hyperflexion position, and at a young age, adaptively, you probably do have a greater posterior slope. But as I said earlier, with the varus knee and the lateral ligament injury, I would never do an osteotomy as a primary surgery. I would make them, quote, fail that initial soft tissue surgery before I would jump to changing bony deformity. Again, that's just my bias because I think the magnitude of an osteotomy as an intervention or morbidity to the patient is so much greater than purely a soft tissue surgery. I don't know if I answered the question.
Professor Charles.
I have a question.
Okay.
You start.
You finish.
I have a question for whoever can answer it. I have about 4 patients, hyperlax patients, to whom I did an ACL reconstruction, and their knees are very stable, but they don't hyperextend like the other side, and they're not happy. So my question is, if there is anything to put in mind for hyperlax patient doing ACL reconstruction, and if we did it and they have this limitation of hyperextension, what can we do?
I will answer that Don Shelbourne from Indianapolis has published extensively on this in our various journals, and he said just what you say. The patient who has asymmetric extension or hyperextension is generally unhappy, and in his mind has a much greater percentage of developing arthrosis or arthritis long term. For me, that patient, and I'd be interested to other speakers in the room, I tension my grafts typically in full extension. And the question is should I be tensioning that patient in hyperextension? And I worry that if I tension my graft in hyperextension, is my knee going to be lax in that functional flexion, that 20 to 40 degrees? I don't know. I don't have a good answer, and certainly be interested in other speakers.
In the hyperextension knee, or the very steep Blumenstadt line, you need to have a good look where the point of the guide wire comes, and you hyperextend and see what happens. And you need to pay much attention to the...
I agree with that, but there are still circumstances where you put that tunnel, that tibial tunnel, right where it needs to be, and you guys say, boy, I'm going to do a notchplasty and keep taking away bone off the roof, and I still get nervous. I don't think we have a full understanding of how to properly tension grafts in these hyperlax patients.
A last word.
Please. Regarding the posterior tibial slope, if it is increased, we consider it as a risk factor for doing ACL without looking at this problem. You agree?
I agree that clearly we were for many years considered notch width is sort of the primary risk for failed surgery. I think now that Zafignini's paper really sort of cements to us that the multiple failed patient, that posterior slope is probably the most common denominator.
And something more important than the posterior tibial slope, a new term that raised itself in the last 3 years, this medial meniscal slope. The medial meniscal slope is more important than the posterior tibial slope.
Well, I think the meniscus clearly is a major secondary stabilizer.
Yeah.
And yes, and in these patients who are meniscal deficient and have an increased slope, you know, they're like I said, they're almost like they have a trifecta of potential failure and complications. And luckily for us in the United States, I'm not sure what your availability for us, but when I doing these surgeries most often, multiple revision ACL with an osteotomy, I'm also usually doing a meniscal transplant at the same time. And again, these are young patients under the age of 25.
So we evaluate everything, should be.
I agree.
Yeah.
Thank you for all professors, speakers, and thank you for audience. And I think this is the end of discussion. Thank you.
Sometimes in the info station, I do a notchplasty. Just a notchplasty. If I see that the ACL is correct, and what I go, I go in notchplasty to give room to the... Yes. This is what...
Maher, تمام. أنا نيمة The next session will be on injured knee ligaments. Unfortunately, our colleagues from Italy was not able to come over here because of outbreaks of corona in the northern Italy, and they will not be able to locate another lecture at that time because this is just a couple of days ago. The first lecture will be given by our colleague Mohamed Elnour on ACL and LACL reconstruction. Mohamed, is this the same address or did you change the address?
This is the same.
The same, okay.
Good afternoon, everyone.
Mohamed, we are late on time, so we need to stick to the time.
I have two lectures, so I have double time.
ما تفرحش يعني.
Good afternoon, everyone. I'm very happy today because our society is getting bigger and more successful. This is the first thing. The second thing, I'm talking about fifth subject, the posterolateral corner. The third thing is that today is my birthday. I'm now 18 years, so happy birthday to me. Today I'm talking about ACL, LCL injury. Should we call it ACL, LCL, or ACL, BLC injuries? Who want to study this? It's not rare to have an ACL, BLC injuries. It's around 11 to 19%. Missed BLC injuries is an important cause of failure in ACL reconstruction with more loads on the graft. Cadaveric studies have shown increased tibial rotation combined with sectioning of the ACL and posterolateral structures. We have three main structures: the lateral collateral ligament, which is the main varus restraint, the popliteus muscle complex, which control external rotation and hyperextension, the popliteofibular ligament, which controls external rotation. The classification of the posterolateral corner by Fanelli is a very famous classification. Grade 1 external rotation, grade 2 external rotation varus laxity, grade 3 external rotation varus laxity. This gives an impression that external rotation is mandatory in posterolateral corner injuries. So it starts with external rotation and then you have a varus laxity. This classification does not give you an idea about the injured ligament, about the method of treatment, about the prognosis. And Labrad have published a case of isolated lateral collateral ligament reconstruction, which means that you have a lateral collateral ligament reconstruction, lateral collateral ligament injury without popliteus tendon injury. Acute ACL PLC injuries, early management is preferred than delayed management. Young active patients usually need surgical intervention. Conservative treatment is reserved for old, obese, non-active patients. The first option is to repair versus reconstruction. Most literature suggests that PLC repair leads to high failure rate, almost 40%. This is a consensus everyone agree about. But this consensus comes only of two papers. The first one by James Strand in 2005. He discussed 22 reconstructions with 2 failures, 9%, versus 35 patients with repair, 22 successful and 13 failures, 37%. All the reconstruction cases was one-stage surgery, doing all the ligaments together. All the repair cases was staged surgery. The other paper was by Prost Levy. He did 10 repairs. He have 6 successful outcomes, 4 failures. On the other side, he has 18 reconstruction with 17 successful reconstruction and 1 failure. So he find out 40% of failure. Again, the repair cases was isolated. The reconstruction cases was combined with all the ligaments. A new paper this year in the Orthopedic Journal of Sports Medicine that there is no difference between posterolateral corner repair or reconstruction with ACL surgery, because they say that the important thing is to do everything together. If you do a single stage, then you do a staged surgery, you put a lot of stress on your repair, and you have good outcome achieved at 6 years follow-up with both repair and reconstruction of the posterolateral corner injuries treated with ACL reconstruction. So repair is a valid option. Avoid repair of multi-substance tears. Select your patient with avulsion injuries. You must protect your repair by managing all associated injuries. So staged surgery leads to more failure. The hybrid technique for acute posterolateral corner injuries is reconstruction or augmentation of the 3 main important structures, the lateral collateral ligament, the popliteofibular ligament, and the popliteus tendon, with repair of other structures like the biceps tendon, the posterolateral capsule, the iliotibial tract. These structures need to be repaired. This is one case of mine. This patient has a femoral avulsion. This is the popliteus tendon, femoral avulsion, and the lateral collateral ligament. I have opened the posterior capsule, and I have opened the iliotibial tract. So you have good ligaments, you have good substance of the ligament is not frayed. This is the popliteus tendon as the popliteofibular ligament, and this is the lateral meniscus. And then I opened the window in the iliotibial tract, and I did repair of the posterolateral corner with very successful results. I put one anchor in the footprint of the popliteus tendon and another anchor in the footprint of the lateral collateral ligament to repair the popliteus muscle complex and the lateral collateral ligament with good results, provided that I choose the good patient and I protect my repair with reconstruction or management of other associated injuries. And here is the posterolateral capsule that I have to repair later. This is a good tension in the lateral collateral ligament after the repair. In chronic ACL posterolateral corner, you have to exclude varus angulation, and you have to do reconstruction of both the ACL and the posterolateral corner. As we are discussing now, the famous noise classification of the primary varus, what you could neglect is the osteotomy. The double varus and triple varus, you have to do osteotomy, either one stage or staged surgery. And this is beyond the scope of my talk today. For reconstruction of the posterolateral corner, you have to know the anatomy. We have 3 important structures, the lateral collateral ligament, the popliteus tendon, and popliteofibular ligament. To notice that the popliteofibular ligament is an insertion of the popliteus tendon to the head of the fibula. So the popliteofibular ligament attaches from the head of the fibula to the popliteus tendon itself. This is another picture. This is the lateral collateral ligament. This is the popliteus muscle and the popliteofibular ligament. And you have to configure this Y-shaped appearance of the popliteus tendon. The popliteus tendon bifurcates into the popliteus muscle and the popliteofibular ligament. So what's the rationale of reconstruction? The first thing is to reconstruct the lateral collateral ligament and the popliteofibular ligament through a fibular tunnel. On the other hand, you can reconstruct also the lateral collateral, the popliteofibular ligament, the popliteus muscle, and the lateral collateral ligament. So you can reconstruct the popliteus tendon or not. This is a matter of debate. Labrad said that the static function of the popliteus muscle is very important, and it calls it the fifth ligament of the knee because it's an important ligament for the knee. Others say that reconstructing the popliteus tendon will over-constrain the knee and make it more painful and leads to arthritis. So debate, should we repair the popliteus muscle because it's an active muscle? You bypass it with a static structure. This is the anatomy, and this is the famous Labrad technique for anatomical reconstruction. He did this one, the popliteus tendon, and this is the lateral collateral ligament. And look here, this structure, he called it the popliteofibular ligament. This is not the popliteofibular ligament because the popliteofibular ligament attached between the head of the fibula and the popliteus tendon. This is the popliteofibular ligament. So what Labrad did is a posterior tibiofibular ligament. My anatomical reconstruction that I would like to do, I do a Y-shaped graft to mimic the Y-shaped appearance of the popliteus tendon. And I do the reconstruction in this way. I do two tunnels, one in the femoral attachment of the popliteus tendon, one in the femoral attachment of the lateral collateral ligament, one tunnel through the head of the fibula, and one tunnel through the tibia. And I pass the graft, one short limb as a popliteal bypass, and the long limb will act as a popliteofibular ligament, passing through the fibula and coming back to be a lateral collateral ligament. And this is a schematic drawing of this reconstruction to reconstruct the popliteus tendon, the popliteofibular ligament, and the lateral collateral ligament. This is a patient with an ACL and posterolateral corner with external rotation recurvatum, varus, posterior drawer test, and ACL. This is a pivot shift positive. This patient has an ACL and posterolateral corner injuries. After I did an ACL reconstruction, I passed the suture for the ACL tunnel. I open a small incision. Then I start to do windows through the posterolateral corner. The first window is between the iliotibial tract and the biceps femoris. So I developed the plane between the iliotibial tract and the biceps femoris. The other one is a vertical slit just posterior to the lateral collateral ligament. This is the lateral head of the gastrocnemius, and this is the lateral collateral ligament. This is a safe window for exposure of the posterolateral corner. Then I open another vertical incision at the head of the fibula in the biceps aponeurosis. Sorry. So I open a vertical incision just posterior to the lateral collateral ligament, and this is the lateral head of the gastrocnemius, and I open another vertical incision and the biceps aponeurosis. In this way, I have a full exposure of the posterolateral structures. This is the back of the knee. It's very safe because the neurovascular bundle is more posterior to the lateral head of the gastrocnemius, and I have a good approach to the back of the knee. After that, I do a small split incision in the iliotibial tract at the femoral insertion of both the lateral collateral ligament and the popliteus tendon, and isolate. I do identification of the footprint. Then I start to do a fibular tunnel from the anterolateral part of the head of the fibula to the posteromedial part, which is the footprint of the lateral collateral ligament and the popliteofibular ligament. This is the shuttle suture for the fibular tunnel. In the same way, I do a tibial tunnel from anterior to posterior. This will be for the popliteal bypass. And I have two sutures. One suture through the head of the fibula and another suture through the tibia. I do two tunnels on the femur, one in the footprint of the lateral collateral ligament and one in the footprint of the popliteus tendon. And I start passing the graft, I start my passage of the graft through the popliteus tunnel. This is a Y-shaped graft with a shorter limb and a longer limb. I fix first in the popliteus femoral tunnel, and I have two limbs. I pass these limbs under the iliotibial tract, and this short limb will go through the tibial tunnel. This long limb will go through the fibular tunnel in this way. And I have to fix this limb to act as a popliteal bypass, and this limb will act as a lateral collateral ligament. Here is another point of debate. Should we put a screw in the head of the fibula or not? If we put a screw in the head of the fibula, you break the link between the popliteus and lateral collateral ligament. So you have a differential tensioning. You can tension the popliteofibular ligament alone and the lateral collateral ligament alone. But putting the screw have the risk of fracture of the fibula. So you have to be sure that your tunnel in the head of the fibula is not so superficial. You have to put it deep, and you have a good pony stop before putting the screw in the head of the fibula. And this is at the end of the surgery. Sorry. You achieved a full range of motion without constraint because you are doing an anatomical reconstruction. You have no constraint of the knee, and you have good stability. And I start early range of motion with no weight bearing. I delay the weight bearing, but I allow for early range of motion. And this is the post X-ray with the fibular tunnel and the tibial tunnel and the button for the ACL reconstruction. And don't miss the tunnel overlap between the ACL and the posterolateral tunnels, because you have to direct to your tunnels of the posterolateral reconstruction more anterior and more proximal. The popliteus tendon tunnel should not enter through the intercondylar notch, and the lateral collateral ligament tunnel has to be away from the ACL tunnel. I have done the arthroscopic technique, and I have showed it many times before. I will not discuss this issue today. For ACL reconstruction, I want to show some hints. This is a patient with an acute ACL reconstruction, and here is a cycled lesion. The remnants of the ACL were torn from the femoral attachment with this cycled lesion. I want to show you the attachment of the ACL to the lateral meniscus and the close relation between the ACL footprint and the lateral meniscus. As we discussed before, the anatomy of the anterior horn lateral meniscus has two parts that attach it to the ACL, and another part that inserts just posterior to the ACL. So in this patient, it was very clear the relation between the ACL to the remnants of the anterior horn lateral meniscus. And this is the anatomical picture of the lateral meniscus and the footprint of the ACL. The other things that I have always in ACL to examine the posteromedial aspect of the knee, and I do always ramp repair when I find a ramp lesion. When I find ramp lesion like this, I do a ramp repair, and it's always included in all my ACLs to examine the posteromedial compartment of the knee. And here is the ramp lesion after finishing this repair. The other things, I have to do an anatomical ACL reconstruction. I have to identify the femoral footprint of the ACL to be accurate. And because a lot of literature saying that everyone is doing an anatomical ACL, there is a new paper discussing criteria for anatomic ACL reconstruction, and they did a checklist for ACL reconstruction. So it's called anatomical ACL reconstruction checklist. You have to do a checklist after your surgery to see if your reconstruction was really anatomical or not. Another point I want to show, this is the view from the anterolateral portal. The knee is flexed 120 degrees. You have to see that this is the femoral condyle, and this is the patella. So the patella in 120 degrees is very near to your portal. So when you are going, when you are going with your drill, you can injure the medial femoral condyle as well as the patella itself. So the half moon drill is not a good option, and I use, as Professor Ahmad Aziz mentioned before, intra-articular coupling of the ACL guide. So I introduce my drill in the direction I want, and this rosette drill, I can do intra-articular coupling of the drill over the guide wire to avoid injury of the medial femoral condyle or injury of the patella. One last trick that I do is called park in the back technique. this shuttle suture for ACL, I tend to park this shuttle suture in the back of the knee to do the tibial tunnel without bothering you. So after I do shuttle suture for the femoral tunnel, I take the suture of the femoral tunnel and I park it in the back of the knee. So I call it park in the back technique. I put it away so I can do the tibial tunnel without any troubles. And this is the tibial tunnel position in the middle of the anatomical footprint. And here is the ACL graft. After I finish ACL, I do repair of the ACL to the remnants, to the remaining remnants. I disagree that the tibial remnants could close the opening of the tibial footprint and prevent tibial dilatation, or theoretically is, I think, like this. My take-home message is that ACL and posterolateral corner augment each other. Missing one ligament leads to failure to each other. Understanding the anatomy of the posterolateral corner is crucial before reconstruction. In probably selected cases, posterolateral corner repair is a valid option. Thank you so much.
Thank you, Dr. Mohamed Elnour. Another journey to the posterior cruciate ligament avulsion. Indication and techniques of fixation, open or arthroscopic, will be presented by Professor Pantelis Nikolaou. Please. Not here. Okay.
Thank you. You can afford me again, sorry. I'm going to talk about posterior cruciate ligament. The treatment of the posterior cruciate ligament injury must be based on the understanding of the natural history of this injury, as well as on an accurate understanding of the long-term results of various treatment alternatives. The factors that should be taken into account when we face posterior cruciate ligament is the severity of injury, if it is isolated or combined, the timing of injury, if it is acute or chronic, the symptoms, it maybe sometimes is asymptomatic or there is pain and instability, and the activity level, if we have an athletic type injured person or a sedentary person. The indications, we can face it with a lot of controversy because the natural history of the PCL deficiency and the difficulties in accurately reconstructing the complex function of the PCL operatively, there is no consensus regarding the indications for PCL reconstruction. If we see here two knees, the first one, there is a grade 3 posterior transaction of the tibia on the femur, but if you see, there is also some associated rotation injury. The other knee, on the lower photograph, there is a transaction grade 3, but there is not rotational injury. So maybe we can think about if we have to operate this type of knee. The different phase of the picture is that the avulsion fractures. Here we don't have any doubt that this must be operated. A small algorithm, if we have acute PCL avulsion and the fragment is large, so there will be an open or arthroscopic reduction and fixation. If we have a small fragment and the tibial translation is less than 1 centimeter, so maybe we can think about a little the conservative treatment. If the posterior tibial translation is more than 1 centimeter, 1.5 centimeter, then we have to do a fixation open or arthroscopic. 4 years ago, the Associate Editor Emeritus, Claude Miller, said that should we repair posterior cruciate ligament tibial avulsion fracture by opening the hood or through a tiled pipe? We see. While the controversy of open versus arthroscopic methods has been settled for many procedures in favor of arthroscopic treatment, the literature shows that posterior cruciate ligament tibial or femoral avulsion fractures can be equally well treated with either open or arthroscopic techniques. The different type of techniques and the different type of fixation has no much difference. The only difference is to choose the fixation method who is based on the size of the avulsed fracture. So in small bone fractures, we can use even sutures. In medium-sized fragments, we can use some Kirchner wires, and in the large single fragments of bone that involve the condyles were fixed with 1 or 2 cancellous screws. So there are advantages and disadvantages in this type of technique. The major problems include loss of reduction, residual laxity, loss of extension, and non-union. In my practice, when I finished my residency in 1981, since 2009, I used to do an open fixation of these avulsion fractures. In 2009, I was in Osaka in an ISACOS meeting, and the John Joyce Award was won by a colleague that showed us how to do this type of operations arthroscopically. And I can tell you, with experience so many years in arthroscopic surgery, I tried it, and I find it very interesting. And in the oldest here, in the older guys here in the podium, in this room, I can tell you, it's a kind of interesting to change your routine and to do something that is really, really good. So I'm going to show some videos. You can go to the posterior part of the knee through the lateral anterior porta, a little higher, and then you can do 1 and 2 portals in the posterior medial aspect of the knee, as you can see here. You can clear the scar tissue around the injury, here with the second portal. This is the fragment. It's not a big fragment. It's not so easy, but after 3-4 times, you find it that it's coming well. Then you pass sutures from the front to the back, and you do the fisherman loop, as we do it in shoulder. And you take the sutures through the holes. You have 2 holes in the front. Here's the fragment on the top, you can see it. And pulling the suture, you can see that the fragment is coming on place. You do 5-6 knots. As you can see, you have enough space on the back of the knee. To tell you the truth, I prefer it than this difficult dissection on the back of the knee with all these nerves and arteries and veins. Now I move the sutures, and as you can see, this is moving in place, and you can see before and after the X-rays. The same, you can do it, and more easily, I can tell you, in the femoral avulsion. Here you use the special instrument that we use in the shoulder to pull the tendons, and then with multiple holes, using the Marshall technique, with small suturing, you pass and you can do the operation. So, I come again to Claude Miller to follow his thoughts. The take-home message is that both surgical approaches were very successful in a very high percentage of the patients, and the surgeon can be confident that he or she can successfully repair the transmission in most cases, whether she or he opens the hood or repair this through the file pipe. Thank you.
Now we open the floor for discussion. One or two questions for each speaker. The first speaker, Professor Mohamed Elnour. Any question? No questions. Okay.
Thanks for a very good lecture. You said that every ramp lesion you look for it and repair it. Do you think that every ramp lesion have to be repaired? I think small ramp lesion you can refresh the edges and leave it. Do you think, or even the small one you can repair?
What I say that post-remedial corner examination is an integral part of my ACL or my knee arthroscopy. I always examine. If the ramp lesion needs to be repaired, I will repair it. If it's a small lesion, just debridement.
Okay. And now questions for Professor Pantelis. Any question? في حد هناك؟ Okay. Professor? Professor. Go ahead.
According to avulsion from the femoral side, you see cases VCL avulsion from the femoral side, and if you see, what we will do? Avulsion from the femoral side of BCL.
Usually, there is not a bone coming in the femoral condyle. Usually, is a part of periosteal
What
leaf.
you will do?
So what I do, I put this special instrument. I do 4, 5 sutures, and I push them to the medial condyle with a guide. You don't need a lot of guided here because it's very easy to go where you like. And then I tighten it on the tip, on the femoral condyle.
As a
femoral
transverse.
condyle. Yes. It's like what Mark did for the anterior cruciate ligament in the acute ruptures. I suture back the tendon, and I think this is easier than the tibial avulsions.
In your lecture, you tell us a small fragment and large fragment. What size of the fragment? What do you mean?
I mean that
about what?
the small fragment is less than 1 centimeter in diameter. Less than 1 centimeter. So you see, this is a small fragment. Then there is the medium type fragment that is from 1 to 2 centimeters, and then the larger is taking part of the femoral condyle. In the posterior cruciate ligament, my thought is to do exactly the complete, let's say, anatomic side, because the insertion in the tibia is too large, too wide, and I try to put all these wide things on place, especially in the large type of, and in the large type of fragment, don't think that it's easy to do it arthroscopically. I go always open. And the other thing, in 35 years of my experience, there are not so many PCL than the ACL. So the number of cases are not so many.
In the first, at the first of lecture, you tell us all cases of BCL must be do surgery.
The fragment.
You tell us, you say depend on instability of the patient.
I said that when we have a fracture in the middle substance, you have to look if the transaction of the tibia is more than 1 centimeter and if there is rotational instability. So we have to go to surgery. In other cases that you have the opposite thing, maybe you start thinking, and depending on the activities of the person, you can go even conservatively. You can think conservatively. But in avulsions fractures, I think, and if the fragment is big, you have to go to do surgery.
Thank you.
Thank you.
Now we have to close. Thanks for both of the speakers and for all of you. And now it is a time of workshop. صورة جماعية يا جماعة.